patients with a non-complicated, simple diagnosis, they get treated for their disease conditions, they go home. Whereas complex patients require a lot of planning in making the discharge happen.
The staff get together and discuss a patient who's been here for 6 days or longer, and we look at their medical status and what are the barriers preventing them from being discharged.
But we've had patients here for far longer than 6 days, and they're not just, they don't just have an infection. They have problems with mobility, they have problems affording their medications. When there's all those barriers in the way, that's what makes it complex.
Our complex care rounds is a group of interdisciplinary members to come up with a plan as a team to best suit the patient for discharge.
So we have to look at equipment for the house, as well as continuing care and VON if needed, and what follow-up appointments they would need upon discharge.
Does the person have a power of attorney? Does the person have a next of kin? Are they a bachelor that lived on their own and they don't have any family members left? It's not just setting up home care, it's making sure the social work is involved, the family is aware, do they need equipment to go home? So that's involving rehab services.
People need to pay for walkers, lifts, incontinence products. All these things are pieces of the puzzle that I don't think are normally thought of outside of medicine, but they're all huge when it comes to discharging someone.
We do run into a lot of these problems that in the short bullet round meetings, we can't always tackle them. But in the complex case review, it gives us time to stop and think about that one particular patient and their unique barriers.
We will look at all options that are available. Sometimes it's accessing a grant or a non-government community organization that might have some services available. It could be accessing housing support workers to help advocate for a patient's need for an alternative housing situation.
I mean, the best place for healing is going to be the home anyway, but we want patients to get home and then continue their care at home. And that's what that home first. If we can get them to continue their treatment at home, that's a bed that opens up and they can continue getting better.
They thrive at home, they start to get better, they start to do more for themselves. It's all about their independence and having a better quality of life as opposed to sitting in a hospital bed or in a long-term care bed and getting depressed.
I find it's very invigorating to be a part of those meetings. We're multidisciplinary, but we become one really quickly when it's something that's outside of the normal disciplines.